recording.
Oh, okie doke.
Dan, I can't figure it out. Oh, I have to be in the room. Okay, I'm not actually in there.
Hey, Ashley,
Yes.
when you're on the main team screen where you have your chat open and you have all your listings down the left-hand side, correct?
Yes.
If you click on the one we're talking about in Teams, click on that. When you go to the right, the screen that opens up, you don't have any options or anything on it. You don't have chat. You don't have.
Wait, there's a meeting options button, but
Click that.
Okay, it's opening up a website. Oh. I've turned it off on record automatically.
Okay. I'm hoping it still says you're recording it.
Yeah, I can't do anything with the actual. I mean, I can join it real quick.
Yeah, that's what you would need to. Yeah, you would have to be in the meeting to do that, to stop the recording. I'm sorry,
Okay.
Ashley, if I confused you there.
Let me see if I can join.
Hey, Ashley, don't worry about it. It's all good.
Hi. Hello and welcome everybody. We have some people trickling in, so we'll give just a few more seconds. And during that time, I will switch over to my PowerPoint. Okay, let's go ahead and begin. So I'm in West Olympia, the traditional lands of the Coast Salish people, including the people we know today and the Nisqually, Squaxin Island, and Confederate tribes of the Chehalis Reservation. I honor their ancestors and leaders who have been stewards of this land and water since time immemorial. We acknowledge their stewardship, their forced removal, and their continued fight to live on their ancestral lands. Welcome, everyone. So today, my name is Ashley Bell, and I go by she and they pronouns, and I'm the Behavioral Health Program Coordinator. I am also the lead for the implementation of 5229, which is the Health Equity Bill. And next, I will have Ross introduce himself.
Hello, everyone. My name is Ross Valori. I'm a policy analyst with the Health Systems Quality Assurance Division, and I'm assisting Ashley on this project, and I use he, him pronouns. Thank you.
Okay. And there was a question, is there an interpreter today? So I will introduce Mary. Mary is our interpreter for today's listening session. All right. Hope, are you online to introduce yourself?
I am. Hi, I am Hope Kilborn. Like Ross, I am also a policy analyst. I go by she, her pronouns, and I am happy to be here. Thanks.
And next, I will see if Omar, are you available to introduce yourself? Okay. With that, Omar is our equity and justice manager. And I do know he had a conflicting meeting that he was going to try to get here as soon as possible from. And Dan, if you'll go ahead and introduce yourself and then go over how Zoom works.
Oh, excuse me. Hello, everybody. My name is Dan Frank. I'm a management analyst in the Office of Health Professions in the Health Systems Quality Assurance Division. I go by he, him pronouns. And I want to welcome everybody to be here. For Zoom, as you could probably tell if you tried to talk, we did had set up this Zoom call to where you would come in muted. So what we're going to do is, as we work through Ashley's going to explain a little bit more what we're doing here. And then what we're going to do is have you guys raise your hands. On the screen in front of you, you should see a button that says raise hand. If you do want to participate and if you do want to speak, we just ask that you raise your hand. And then what I'll do is call on you and I will do my best to pronounce your name correctly. So I ask for some grace along those lines and then unmute you. And then you could go ahead and share your testimony or whatever story you would like to share. Any questions? Perfect. Thank you so much for being here.
Thank you, Dan. So real quick, before we jump right into the action, I do want everyone to please keep in mind the following. Be mindful and respectful to all those who attend, and please, as stated before, raise your hand to speak. Staff will unmute you. Please be aware of the time you use when you're speaking. If you go beyond allotted time of 3 minutes, staff may have to ask you to finish your thoughts so we can move on. And I have integrated in a visual cue, and it will let you know in yellow when you have a minute left. And then in red, it will say, hey, you're out of time. Please stay on the topic of health equity. And if you share on other topics, staff will have to thank you for sharing and move you along. And this is a listening session. So we will not begin drafting the rules or talking about the rules, but instead this is a period of time for you to share your experiences and with health inequities and racism. So during this time, we will ask you, if you haven't done so already, complete a survey. And so why complete a survey? Well, we want to make sure we're reaching out to the diverse group of individuals and recognize that if we're missing a demographic, we need to adjust the ways we're reaching out to different groups of individuals. The survey is voluntary, and you do have the option not to answer a question. But this survey is subject to public records requests, but you'll remain anonymous if you don't have any identifying information, such as putting your name or your address, or even where you work in the open text field. So real quick, I wanted to explain, well, why are we here and what's health equity? Well, health equity exists when all people can reach their full health potential and they're not disadvantaged because of their ethnicity, their race, their sexual orientation, their gender identity, the neighborhood they live in, how much money they make. Everyone has the opportunity to reach their full health potential. Equality and equity are not the same though. Equality gives everyone the same resources so that they can reach their fullest opportunity. Equity gives people the resources they need so that they can reach the same opportunities. And health inequities have always existed. It's just that the COVID-19 pandemic has really highlighted health inequities in the healthcare system. So what is this bill? Well, the Engrossed Substitute Senate Bill 5229, or ESSB 5229, or what we like to refer to as the Health Equity Continuing Education Bill, was passed by Washington State Legislature in 2021. And it requires that healthcare professionals take continuing education on topics of health equity. The goal is to help providers think about their own impact on others, and it hopefully will change the way providers work with others so that they can reduce inequities. So what do we need? Well, we want to learn about your experiences. We want to better understand how individuals are harmed, be aware of the role that health inequities play in the health system. We want to see where there can be some transformation, and we want to reach out to a group of individuals that DOH usually does not hear from. And so these listening sessions are really an opportunity for us to hear from you. And so with that, we'll begin the listening session. And what we'll do during this area is we'll take raised hands, and it'll be an opportunity for us to hear what you have to say. And so we would like to know, what does health equity mean to you? What are your experiences with health inequities, and how have they affected you? How can healthcare professionals improve so that they are providing fair healthcare? And is there anything else that DOH needs to take into consideration? Now, as a warning, some of the information shared may be troublesome or disturbing. Please take care of yourself and participate in ways that ensure your comfort. And with that, I will stop talking and I will look for hands, or Dan will. Thank you.
Would anybody like to share? No hands at this point, Ashley. Ross, we got a hand. I'm going to go with Ross. I believe that's how you pronounce your name. Correct me if I'm wrong, sir. Or, sorry, correct me if I'm wrong. And you should be unmuted.
Yes, it's Ross. What does equality mean to me? Healthcare, what it means everyone have a fair and access to the program that they need in healthcare. Yeah. Can you hear me?
Yep.
uh, my experience of healthcare is like, I don't know, I've been on DHA for a long time, so my experience is good and it's okay, but I wish that there is a lot of other equal opportunities since I did the care and everything. So yeah, the care, hearing care, and how that my healthcare for my health, I don't know. What I need from the area to grow. It's more program for mental health people. Thank you.
Thank you so much for sharing.
Thank you for sharing.
Next, we have Sydney. You are unmuted.
Yes, hi. So what does equity mean to you? Equity means to me is to be able to take care of yourself and also to let healthcare professionals know that you have a disability so they understand better and then they can help further educate other medical providers around them to make sure that they treat people with disabilities right. What are your experiences with health equity, if I'm saying it right? And how have they affected you? My experiences with health inequity is when I go to medical providers and I don't even tell them that I have autism, and they have a hard time. I have a hard time understanding their medical questions. And whenever I would have appointments, I would always have my parents to go with me in case I have a second set of ears with me. How can healthcare professionals improve so they are providing fair healthcare? Just understanding that to respect people who are on disabilities more, because they might not understand what medical questions they're asking. Is there anything DOH needs to take into consideration? So, some of us may walk and talk differently, but we are just like everybody else on the outside.
Thank you for sharing. And I really appreciate that, and we all do.
It looks like we have Troy next. Troy, you are unmuted.
Okay, can you hear me okay?
You betcha, you betcha.
Okay, I'm sorry. I was over in the Teams section and just got over here. So, so are we answering the questions on the screen here?
Yep.
Okay. You know, for me, as a person, you know, with lived experience with opioid addiction in the past, you know, equity to me really means the ability to connect to the services that you need when you need them, regardless of background, regardless of financial ability. And in my experience, when I was seeking help, many years ago to deal with my addiction issues. Accessing the healthcare system through the emergency department was a very traumatic experience. It was not something that I was prepared to be treated the way that I was, and was told basically, if you're one of those people, so you'll have to sit and wait until we have time to deal with you. And so that was an eye opener. It was not something that I expected going into it, as it took a lot of courage to try to seek help, and expecting our healthcare system to embrace that and not receiving that was a very difficult experience, to say the least. I think it's important for healthcare professionals to understand that these are folks who are coming to them from very difficult circumstances and very desperate situations. And that just because of the illnesses that we're experiencing don't look like some others that are treated differently, we as human beings shouldn't be treated differently at all. And that our window for help, it oftentimes is much narrower than many others. So that's all I wanted to contribute. Thank you guys for listening.
Thank you for sharing.
Anybody else would like to share?
Hi, Dan, this is Omar. So I just also wanted to clarify for folks that these questions that are on here are more just there as like to give folks ideas of potentially topics they would like to talk about. But in overall, if you'd like to provide a story that may not fit here, but it speaks to your experiences within the systems regarding either equity or inequities, this is kind of your time. The questions are more of like a guide if that's something that people would need.
Thank you for explaining that, Omar.
Looks like we have a Ross up again. You are able to, there you go.
Yeah, I'm gonna go on the regular advanced emergency room, and I'm with the healthcare. I think it's another good idea for people that have emergency with the health crisis in the same room as the emergency room, because they need more than just to tie them down, and just like you have to tie them down before put restraint, and they'll treated like animal, and there is not a good way to do in the emergency room. Yeah.
Thank you. Anybody else? Hi, Mary.
So I just wanted to share something from a training that I took over a year ago now through the Institute for Healthcare Improvement, and it was related to this topic. And I'm thinking about one of the things that you mentioned earlier, and maybe we'll get to it, I'm not sure, but what I see, how can healthcare professionals improve so that they're providing fair healthcare? What struck me in that other session that I took is that providers learned that, who are really working on this, needed to make themselves vulnerable, and they needed to be humble, and they needed to acknowledge that they didn't know everything that about every culture, and they didn't know about the health, just cultural issues around delivering healthcare. For example, you know, in some parts of the world, and people are living here in the States too, and here in Washington, it may not be permitted for a male provider to examine a female patient, and certainly not to answer questions. Like a male family member might need to be there in order for everybody in the family to feel comfortable in that healthcare environment. And so one of the examples that was given in that training was the provider just acknowledging, I want you to be comfortable. I want you to be able to follow instructions so that you can take care of your own health. But I may not understand what you need. I need you to be honest with me and open. If I do something that makes you feel uncomfortable, I need you to tell me it's not intentional. That's not what I want for you. And so that's what I mean about just being humble and vulnerable, and which is not comfortable for our healthcare professionals, right? In our culture, they know all. And so for them to say, I need help understanding what it is you need from me and how I can best help you, is, I think, a big lesson that our healthcare providers can take away.
Thank you very much, Mary. Anybody else like to share? Kristen, you are unmuted. Kristen, are you there?
Hello, can you hear me?
Yeah, we got you.
There we go. Okay. I'm sorry if you can hear my cockatiel in the background. She's very talkative right now. I work in community mental health, and one of the things that I've noticed a lot is the inequity that exists in access to mental health treatment. One of the things that comes up a lot for my clients is the loss of Medicaid and that transition to having to find a new provider. A lot of the people I work with, one of their goals is to gain employment. And then once they do so, their income increases to the point where they can't access Medicaid anymore. And then they immediately lose access to services at community mental health agencies and suddenly have to navigate finding a healthcare plan that works for them, finding a new provider, which can be really challenging. So just having that income change impact a person's ability to access care that they feel comfortable and familiar with is a really big issue that I've noticed. Thank you.
Thank you so much for sharing. Anybody else that would like to share? Okay, Mary, go ahead.
There was just one other takeaway that I had from that, again, from that course I took before. Some things are not necessarily what we would think of as health equity. But when I'm thinking about what the healthcare provider can do, they can adjust their hours in their clinic. If we think about healthcare equity, if we have people who cannot take time off work during the day, that makes healthcare inaccessible to them. For example, if they live in, if they work in Seattle but live down here, it's really hard to get to an appointment down here in Olympia during the middle of the workday. They got to take a full day off work. That's not equity. And so in order for equitable care, they would need to be able to have visits in the evening, possibly on the weekend, in order to be able to access healthcare. So it's not always this sort of obvious kinds of things, I guess, is what I'd like to say. That it's not, to make care equitable, it's not just the things that we think about in terms of race or culture, which are sort of come forth more obviously, or disability, or sometimes there are very real infrastructure issues, solid infrastructure issues that can be adjusted and make a big difference for people.
Thank you for sharing.
See another hand up, Dan. Peaks. Taifa.
My fault on that. Sorry for being slow there.
Hey, I just need to check my volume. Is it okay?
Yep, you're
Perfect.
Good, loud and clear. Thank you.
So actually, yeah, this is Taifa. I'm go by Nomi. I'm a DOH employee. I just wanted to put it out there that I'm speaking as myself, not as a DOH employee tonight, but I wanted to share something that a coworker said to me, and it's a strong statement. So I just want to put the warning out there, but I think it's important to state that quite a few women I've spoken to, in addition to my coworker, they feel like for a Black woman going to the doctor, it's like a Black man being stopped by the police. And that there is fear of potential misjudgment and violence that accompanies that misjudgment. And I have to say that personally, I have experienced unfortunate things as a Black woman at a doctor's office, and things that I still am not able to talk about. So I understand exactly what my coworker was saying. And I thought it might be helpful to share tonight that even though it's a very charged statement, I think a lot of women feel that way. They're not sure that they are going to be treated with care when they go to a doctor, and they're not sure that they're going to be heard. And then also, because they're in a vulnerable position, often they're not sure if they will be met with violence when they're at a doctor's office. So thank you for letting me speak.
Thank you for sharing.
Next, we have Sydney.
So I have just something to say. Even though I haven't been to very many doctor's offices because I'm a very healthy person, it's important to let your healthcare providers and doctors to know that you have a disability, to better understand you more and to educate you better. So in case when they ask you medical questions, that it's in case you don't understand it, they can clarify it with you.
Thank you for sharing.
Anybody else like to share? Hey, Ross, you're up.
Okay, I think that their program should be approved with a program, not a program where you have a disability into one program element program. I think they should be based on the age, based on the ability. Because I hear that there are programs out there like for life, like putting people in one room and just really make them feel like it's like a daycare center. And I don't think that the program should be like a daycare center.
Thank you. I am going to butcher this, so please forgive me. Sephamayas, is that correct?
Yes.
Hi. Hi there, loud and clear.
Can you hear me okay? Hi, I just wanna just say some statement that I think I have been working in healthcare for many years. One of the things that really struck me was that as our Washington State, our most vulnerable people are being pushed around, moving different area, and also their access of healthcare is becoming a very hard in some area. And that is one thing that sometimes people are not able to find a good providers. And also once they find a good providers, there is a lot of obstacles that it's may face, such as language barriers, cultural barriers, and many also like assumptions. I feel like some community have been just assumed assumptions being made without valid information, without being asked clear questions. And speaking in some communities, I really need language being translated. More community are need to be being educated what they access to, because a lot of people moved from the Seattle area, moved more on the south. A lot of the times, those people, they do not have equitable health access. Sometimes they don't have interpreter that's available. Most of the time is they've been used interpreters, which is sometimes it could be mistranslated or interpreted. That is one thing I would like to address, that DOH may aware of that. They need to kind of focus on as a community in the South and growing to be mindful what those community needs. And the other thing that I would like to say is also as a pandemic is being unfortunately affecting a lot of lives and many people around the world, yet people are suffering with inequality of health and food insecurity. And often when patient comes to the clinics or see health for search for help, they often come with hungry. And one is the provider speaking to, the providers, they would like to address the medical issues, which is sometimes that's not their first priority. The second priority, it should be how are you doing on the medical care. First priority should be is how is they already have they may be coming to the clinic hungry and they may not have what I'm trying to say. If we can provide, some clinics, kind of pantries, people can eat, you know, the state can invest that some kind of programs people can go and grab before their doctors. Because when someone comes like 200 above of their blood pressure, only thing they come almost like, they're not worried about their medical, they worry about their stomach. So I just want to have a, just want to put out there, if anything the state can help food pantries, especially in our homeless population, are really suffering. And I have a lot of cases, one case that one patient came to the clinic and she was very much, she is our senior citizen that who is worked all their lives. And she comes to the clinic, she hasn't had any breakfast. And the provider is thinking about was, how's your blood pressure? So I think those kind of issues need to be addressed as a state. That's what I would like to say, and thank you for listening.
Thank you for sharing.
Anybody else have something they'd like to share? Ashley, I'm not getting anybody.
Yes, I don't see anyone as well. We can also answer questions, but we can also sit here and wait. In the meantime, if you do not feel comfortable sharing or you have thoughts maybe that pop up later on, feel free to email us your comment, and we'll go ahead and add it to our information. I will put the email back in the chat. And if you haven't done so and you're willing, please complete the survey. We would really appreciate it. But again, it is voluntary. And while we wait, Hope or Ross, would you share a little bit more about our next steps and what we are hoping to achieve and kind of the timelines?
Sure. Thank you, Ashley. This is Ross Valore, policy analyst with the Department of Health. First, I just want to thank everyone for attending and thank all those who shared. We really appreciate it. In terms of next steps for this project, we have one more listening session that will be on February 24th at 10 a.m. And then once we complete these listening sessions, the next step will be our rules workshops, where we will discuss proposed rule language with the public and take input and adjust the language. And those will be, the first rules workshop will be on March 7th at 2 p.m. The second will be on March 21st at 1 p.m. And the third rules workshop will be on April 4th at 1 p.m. Once we complete the rules workshops, the agency will work with the health boards and commissions to finalize the rule language for the notice of proposed rulemaking. And we hope for this to be filed in July, and then hold a public hearing where the public can come and comment on the rule language for the health equity continuing education program. Hopefully that will occur in September again. And all of this is with the goal of hopefully having the final rule filed in November. So that's a big picture of this rulemaking project for the health equity continuing education programs. Thank you, and I'll pass it back to you, Ashley.
Thank you so much, Ross. And someone asked in the chat, about the survey and where it's located. And so it's located through the link. It's a Fortress Gov link, and a little bit more about the survey. It does ask some demographic questions, and we're hoping to take that information and see how well or where we can improve our outreach efforts. This includes perhaps maybe more communication, more outreach in certain communities such as Eastern Washington or Central Washington, and really also lets us know who's participating as well. And so the survey really gives us a wealth of information, and really can factor into our future work around health equity and other implementations. Once again, it is voluntary, and it is subject to public records requests. You can maintain your anonymity though, especially if you don't include any information that would identify you as the one that answered. So at this time, while we're waiting, is there any questions that you may have? All right. Seeing none, I'll go ahead and I'll just sit in silence, but just know that I'm here and I am listening. And oh, there is a question. Once the rule is implemented, is there a plan for developing or delivering training? I'm actually glad you asked that. So once this rule is developed and we go through the process, it actually needs to go through a secondary process first. And that secondary process is all our boards and commissions would then adopt the model list of rules or perhaps make their own. And when we say the model list, we're talking about these minimum standards, what this education must teach. Once their work is done, we do need to provide a free training option to healthcare providers. Now, that doesn't also limit individuals or other companies having a paid version, but we will look at what fits that minimum standards, what fits those model rules, and approve this training. So we don't actually develop the training, but we do guide what that training actually looks like. Now, of course, everyone can go above and beyond, and we would look forward to that. But we won't be the ones that actually develop this training. I'm not sure if that answers your question completely. And if you have follow-up questions, I will answer that as well, or someone else from my team. All right, that's great. Thank you. Okay, I'm going to go ahead and go back to the slide with the questions, and unless there's any other ask of me, I will sit here. But again, I am paying attention. Ross, I see your hands up. Dan, I'll let you do your magic.
Yep, he's all set.
Yeah, I got another question about the way that the disability is treated when they go to the emergency room, or if anyone that have a medical crisis, and I don't think emergency room is a good idea to send a person that needs a mental health crisis. I think that they could go to a different building or a different medical treatment where it's appropriate in the emergency room, because I've been in the emergency room and I don't like it. Whenever in a mental health crisis, I have to get tied down, and that could really make more damage than it is to help people with any need. So yeah, I don't like the way that they are getting treated in the emergency room. So yeah, I think we should have just keep them away from the emergency room, because when people are going in there, they just go there and they are like getting tied down, getting treated like animals. I just don't like it. I've been in that situation before, and I don't think it's a good idea to put people in every straight in the emergency room, because that they see more than just what they want. So yeah, I think it's better to have a different kind of way to do the emergency room.
Thank you for sharing, Ross. Thank you for your comment in the chat.
Okay, I have a question. And the emergency room is the only way to get emergency help for people with mental illness.
Can you?
And my question is the ER is the only way to give help to a person that need mental health emergency need?
Ross, if you have the ability to, if you can provide your email or some way for the right person to answer your question, I will make sure that gets passed along.
Any of you can answer my question. Is do the emergency room is the only room to get emergency mental health service?
So unfortunately,
Hey, Ashley.
Okay, Hope.
Ross, if I'm understanding, are you asking if the emergency room is the only way for a person to get emergency care?
Yes.
Okay.
Ross, are you asking about mental health as and specifically?
Yes.
Okay. So unfortunately, I don't have the expert knowledge to answer that question for you, but I can reach out to the person that would know the answer tomorrow.
Okay. Yep. Okay.
If there's a way to reach out to you, if you could provide that with us or provide that to us, I will make sure we get you an answer to that question. All right, thank you. I have that. Okay. Omar, did you want to share any thoughts? I know we started without you. Or anyone else for the team?
Hi, Ashley. No, I didn't want to share. I didn't have anything else to share. It was mainly just around the conversation and making sure folks understand, like we were on the same page about like having these questions out here, but more as a guide rather than, them needing to be answered directly. But yeah, nothing to add. I appreciate that though.
Thank you. Well, we do have a question. Is there any way you're going to make sure that information from the trainings is consistent across professional disciplines? That's a really great question. This first go around, or this first phase, sets the minimum standards for the trainings for all secretary professions. And so you might be wondering, well, what's a secretary profession? And really, it's a profession that advises the Department of Health on different matters. And so some of those professions might be licensed counselors, certified counselors, and so forth. So all those professions will have the same minimum standards in which this training has to address these certain things. Now, with the boards and the commissions, they make their own rules. And so a lot of them are participating and they're listening and they're learning about this process. But there is the possibility that these professions, such as nurses and doctors, may make little changes to what they see as minimum standards for health equity training. So we can make sure it's consistent to some point, but we don't know what those boards or commissions will do. What I can tell you is that the bill itself has some language around what must be included in these trainings. And so that's looking at individual biases. That also looks at systematic issues. And the list goes on and on. And so those things need to be taken into consideration and built in. But we do the listening sessions so that we can also understand some of those other pieces. And really, when we get to the rulemaking portion of this, we can see, okay, this training is addressing bias, but also individuals have said they've experienced this, and we need to make sure that this training also touches on those aspects as well. So the short answer is there any way you're going to make sure the information about the training is consistent? Everyone has access to the same stories and same comments that we are listening to today, and we've listened throughout this experience, and we will continue to experience as we go through this process. Can we make sure they're the same throughout every single profession? We can't, but chances are they're going to be very close, if not the same. So I hope I answered that question, and I can have someone else jump in real quick if I missed something. All right. So at this point in time, it's 6 p.m. And I thank you for sticking through this with us. We talked about our next steps, and we'll have our final listening session next Thursday. So if you want to join, you are free to join, and then we'll get into our rules workshop, and we'll send out another release with our rules workshop information. You guys have a nice evening, and I'll see you next time. Thank you.